very much, Susan, for the introduction. I changed the title a little bit. We like to call it a healthcare no-brainer in Canada. Healthcare no-brainer being doing smoking cessation. And certainly in hospitals, we heard earlier today, for those of you who are here, hospitals are really great settings, and it's a great opportunity to actually help smokers quit smoking at a time where they might be most highly motivated to do so. So I'll talk a little bit more about the intervention that Bob Reed spoke of this morning, the Ottawa model for smoking cessation, and a specific study that we embarked on looking at some of the downstream consequences of the intervention. So you may have seen this slide earlier this morning. Here's sort of the situation in Canada. We have about 35 million people across the country, most living along the US border, actually. Our smoking prevalence is about 16%, so we have between 5 and 6 million smokers. But what we also have is, or what we also know is, we have about 750,000 to 1 million hospitalizations involving smokers every year. So yet another sort of rationale for why we would provide smoking cessation interventions in hospitals. There are about 1 million people who smoke that go through the hospital system every single year. So what does that mean on a daily basis? On any given day in Canada, there's about 23,000 hospital beds that are occupied by current smokers. So that's about 20% of all patients in hospital. You can see the smoking prevalence in hospitals. It's higher than the smoking prevalence in the general population. Well, why is that? Because smoking-related illnesses are one of the leading reasons why people are coming to hospital in the first place. They're also leading causes of rehospitalization. So people continue to smoke. We're going to see them coming back to hospital again and again for some of the same reasons, and also a main reason for ambulatory care or emergency department use. So earlier, Bob presented some data about the efficacy of the program in terms of helping people quit smoking. By offering the Ottawa model for smoking cessation, our earlier trials demonstrated that we were able to improve cessation rates by around anywhere from 11 to 15%, depending on the patient population we're talking about. In a general hospital population, we know that about 30% of people will remain smoke-free following the intervention over the long term. So that's great. We tell our healthcare funders, hey, we can help people quit smoking. But they say, well, good for you, but what does that mean in terms of cost to our healthcare system? In Canada, we have a publicly funded healthcare system, so all necessary medical procedures are covered under a provincial insurance plan. Every province has one. So, in terms of trying to make the case for implementing behavior change interventions, or any intervention for that matter, often healthcare administrators are looking for that business case. Well, what is it going to cost me, and am I going to save any money in the end? So good for you, smoking cessation people. Really, what is the bottom line in terms of what this means to the system? So we went about to answer some of those questions in doing some detailed cost analyses, which I'll describe in a moment. So really our question was, what impact does providing a hospital-initiated smoking cessation intervention, and in this case the Ottawa model for smoking cessation, have on mortality, healthcare utilization, and cost? So here, again, is a summary of what the Ottawa model is. It's essentially an organizational change intervention, actually, where we help hospitals, primary care clinics, and other settings implement a systematic approach to identifying smoking status of all patients, documenting in a systematic way, in a standardized way, the smoking status of all patients every time we see them, providing strategic advice or practical advice, and in the hospital setting that's at the bedside, sort of that initial advice to quit given their health condition. its offer of pharmacotherapy, one of the first-line pharmacotherapies for smoking cessation, and enrolling patients in long-term follow-up beyond the hospital stay to help prevent smoking relapse and offer support over the long term. So we've been able to implement or work with over 400 healthcare settings across Canada to implement this program. We've reached about 350,000 smokers over the years, and these days, or on an annual basis, our partners are intervening with about 40,000 smokers per year, closer to 50,000 these days. So in terms of this study, we looked at, or it involved 14 hospitals that at least pre-implementation were planning to implement the Ottawa model. So I'll go through the design in a moment, or go through the design now. So in each of these hospitals, prior to implementing the intervention, we selected a pre-implementation control, or a usual care group. So what we did in all 14 is we screened a consecutive series of patients over about a 1-month period to determine smoking status, and also among the smokers to call them 6 months later and find out how many of them had sort of spontaneously quit smoking without any intervention in the hospital. So in our pre-implementation control group, we enrolled 641 smokers into the study. Then we worked with each of these hospitals to implement the Ottawa model, those 5 systematic steps I just showed. And after implementation, after the hospital had been implementing for at least 1 month, we repeated the exact same method for recruiting the control group, which is to screen a consecutive series of patients at each hospital. In this case, the smokers received the Ottawa model intervention. So our intervention group consisted of 726 current smokers that received the program. Earlier we had talked about the Institute for Clinical Evaluative Sciences in Ontario. This is an institute that collects all healthcare administrative data in our province of Ontario. Every time someone uses their health insurance card or their health card, all the information from their hospitalization, their primary care visit, their surgery event gets stored or gets sent to iCEPS, not ISIS, and is available through data linkage. So what we were able to do is link the data from both of our groups to this healthcare administrative data in order to collect the following outcomes. So we looked at all-cause readmissions after 2 years, smoking-related readmissions, all-cause and smoking-related emergency department visits, physician visits, mortality, and then cost to the healthcare system. In terms of the statistical methodology, we use competing risk regression. Essentially what this means is it looks at the cumulative incidence of an event, or so it's almost the opposite of a survival analysis, where it looks at the probability of an event occurring over time, but it deals with the competing risk, and in this case, death. So, for instance, if we're looking at the outcome of rehospitalization, and we want to know how many times someone is rehospitalized, or all of our participants are rehospitalized over a 2-year period, if someone dies, they're no longer at risk of being rehospitalized, so it adds bias to the analysis. So we were able to adjust for the competing risk of death. In terms of looking at the cost outcome, we used a regression analysis that deals with censoring, and it looks at costs in monthly intervals over the 2-year period, and also adjusts for that competing risk of survival. So some results, I'll just draw your attention to a few things. This was an observational trial, of course, so we did see differences at baseline in terms of the proportion of patients who had experienced AMI, acute myocardial infarction, or heart attack, any history of heart attack, and also history of cancer. There's a significant difference in terms of groups. So I'll go back to that in a moment, because we did look at, we wanted to know if these impacted our final outcomes, and we did some additional analyses to look at that. For those of you working in the smoking cessation world, not surprisingly here that in our hospital population, 50% or close to 50% of people in both groups were in the lowest 2 income quintiles. So again, those of us who work in the field, this is not a surprise, but you know, just a reminder of sort of the some of the other challenges that smokers might be facing, you know, in their lives beyond simply trying to quit smoking. In this study, we found a significant difference in smoking cessation rates between groups. So the pre-implementation control, about 20% of patients were smoke-free at follow-up, compared to 35% of those who received the Ottawa model, and this was using an intention to treat analysis. So for our main outcomes, we looked at up to 2 years, but we looked at the short-term outcomes as well. And so at 30 days post-intervention, patients who received the Ottawa model for smoking cessation were a relative 50% less likely to be re-hospitalized within 30 days. You can see the, do I have a point? I don't have a...
Yes, here.
I do. Oh, that's all right.
You
okay.
have...
You can see the absolute risk reductions there, as well as the number needed to treat. So we only need to treat 16 smokers in order to prevent 1 re-hospitalization in the 30-day period. Most governments these days are really interested in this 30-day readmission period, and certainly in our province, hospitals are accountable to reporting or strategies. What are you doing to prevent this 30-day readmission issue, because it is a significant issue. When we looked at smoking-specific readmissions, so respiratory health issues, cardiovascular issues, and so on, we saw very similar reductions. And we saw significant reductions in emergency department visit in the 30-day period as well. When we went out to 2 years, we continued to see significant reductions in readmissions and ER visits, but most surprisingly, I would say, was the significant reduction in mortality at 2 years. We saw an absolute reduction of 7%. So from a patient perspective, probably the most important finding in our study is, you know, we've known for decades that quitting smoking is the most important, or very important thing to do in terms of increasing life expectancy, but certainly even among high-risk smokers with pre-existing disease, we're seeing that within a short period, a significant difference there. Just interesting in some of our, in our stratified analyses, that going back to that low socioeconomic status group, when we looked at the impact of the intervention on those with low socioeconomic status versus higher SES, we actually found that the intervention had a larger effect on those with lower SES. So in other words, if I have high income, I'm a smoker, and I receive the intervention in hospital, well, it doesn't matter whether I receive it or not. I'm probably going to either quit smoking or not quit smoking either way. However, if I receive the intervention and I'm a lower income patient, it's more likely to have an impact on me. And so I think this is important, you know, when we think of reaching interventions, you know, reaching large proportions of the population, and certainly reaching some of those more vulnerable groups in our population. Again, a systematic approach in the hospital. You know, we ask everyone about your smoking status, and you get the intervention regardless of your background. And so this is, you know, another way of, or a great way of reaching all types of patients and having a significant impact on groups that traditionally are very hard to change. So in terms of the cost outcome, what we looked at, I mentioned that, all medically necessary interventions are covered, or treatments are covered by our government. So we looked at, in terms of cost, the cost of inpatient admissions, ER visits, physician services, so that's primary care physicians, same-day surgery, long-term care, and home care over a 2-year period in both groups. So what did these folks cost 2 years later after their intervention? And before adjusting for survival or mortality, there was almost a $3,000 difference in terms of the cost, the per-patient cost, over that 2-year period. And once we adjusted for mortality, again, mortality being higher in the control group, it would have biased this outcome toward the control group. We see about a $4,000 difference between per patient over the 2-year period between groups, which is a lot of money when you multiply those million smokers that we see in hospitals in Canada every year. The greatest impact in terms of cost, patients with asthma, COPD, diabetes, and 3 or more chronic diseases saw the greatest reductions in terms of overall healthcare costs over the 2-year period. What does this intervention cost? This is what it costs our province if 100% of every hospitalized smoker took up 100% of the intervention components, which we know is not entirely true. But worst case scenario, this intervention costs $80 per patient, per smoker. You throw in pharmacotherapy and then full course of treatment of 12 weeks of medication, and now we're talking about a $440 cost per patient. So let's say that's how much it actually costs when we know it is actually lower than that. Spend $80 to save $4,000. We say that's a healthcare no-brainer. Your return on investment is between about $8 to $50. So to conclude, smoking cessation interventions that begin in hospital and offer follow-up post-hospitalizations like the Ottawa model are effective at helping people to quit smoking. It improves their survival, decreases healthcare utilization, and reduces costs. There's a need to prioritize smoking cessation within healthcare systems as a key strategy for the management of chronic diseases. I'd like to acknowledge my colleagues on this paper, the Smoke Free Ontario strategy, and I forgot my shameless plug slide, but we do host an annual clinical smoking cessation conference every year in January in Ottawa. January is a great time to come to Ottawa, right, Robert? It's our 10th annual conference, so it's going to be really big this year. I wish I had the slide because the exact dates escape me, but January 21st, 22nd or so, please feel free to come to Ottawa if you have an interest in clinical tobacco cessation, and I'll stop there. Thanks very much.